Hi, everyone. Welcome today. I'm Dr. Tanya Stevenson, the CEO of the Myotonic Dystrophy Foundation, and we are thrilled that you are joining us. Today, we're kicking off our second in a series of Ask the Experts. We're going to be talking about lungs and myotonic dystrophy today. As a reminder, the MDF mission, Care and a Cure, is to enhance the quality of life of people living with myotonic dystrophy and accelerate research focused on finding treatments and a cure. MDF's work focuses on support and education, research, and advocacy. We have tons of resources and support opportunities available on our website. So we have toolkits, publications, clinical care guidelines, all of our support groups and Facebook chats, calendar of events and activities is on our website. And of course, today's presentation and all of our presentations, including those from our past conferences, are available on MDF's Digital Academy. We're excited to declare International Myotonic Dystrophy Awareness Day, September 15th. Please consider joining the Global Alliance at myotonic.org/international-DM-day. Throughout the year, we are going to be planning some really fun and big events that will take place on the 15th, and we hope that you will help engage and make the world aware of myotonic dystrophy. So we do have our Meet the DM Drug Developer Series still happening the first Friday of every month at 12 p.m. Pacific. So we've had two fantastic sessions so far. The next session is April 2nd with Expansion Therapeutics. You can register for any of these sessions at myotonic.org/meet-dm-drug-developers. And one note about our Meet the DM Drug Developer Series, although they are all happening on Friday, we had so much interest. There is a bonus session happening on a Wednesday, June 9th. So don't forget to add that to your calendar. As today is our Ask the Expert series, please don't forget every third Friday of the month until our conference in September, we will have a different topic focused on. We will invite experts from the DM clinical community to talk with us about different issues. And next month, we will have on April 16th, gastrointestinal impacts of DM. So get your questions ready. Register for these sessions at myotonic.org/ask-expert-series. All of our sessions will be recorded, including today, and will be posted to the Digital Academy. Usually takes us a couple of days, so please be patient just so we can get it up, but we will send out the recording as soon as it is available. You can also check out myotonic.org/digital-academy. Any questions you might have about this session or any other sessions, please don't hesitate to contact MDF. Our phone number and our email address are here. So we are asking our lung health expert today. If you have questions for Dr. Sansone, you may go to the chat box and use the drop-down menu, select send question for staff, and send it that way. So there are two options here, and I just want to make sure it's really clear how to send a question to Dr. Sansone. So make sure you use the chat box, but use the drop down to select send question for staff. That's the only way we'll get those questions. For those of you who registered and submitted questions in advance, thank you very much. Those questions were sent to Dr. Sansone and they've been integrated as much as possible into her current presentation. So it's very exciting and it's very comprehensive. All right, so today it's time to meet our expert. Dr. Valeria Sansone is the Clinical and Scientific Director of the NEuroMuscular Omnicentre, also known as the NEMO Center, in Milan, Italy, and she is a professor of neurology at the University of Milan. Dr. Sansone has extensive clinical and bench science experience in neuromuscular disorders from both clinical and basic science perspectives. For the past 22 years, she's cared for patients with muscular disorders at the Department of Neurology at the University of Milan, as well as patients at the National Neuromuscular Clinic at NEMO. Her main field of research includes the myotonic dystrophies. For decades, Dr. Sansone has been caring for people living with myotonic dystrophy on a daily basis. She works with her interdisciplinary team to find the best treatment for respiratory issues in the DM community, as well as all other symptoms. I want to especially thank Dr. Sansone today because she is joining us from Italy, and it is already after 8 o'clock in the evening for her, so we are grateful. Okay, thank you all for joining us, and I would like to welcome Dr. Sansone.
So thank you very much. I am very honored to be here, and I hope I will be of help to answer the questions that you have when we think of myotonic dystrophy and the lungs. So the first thing, the way I tried to get back to you with the questions on respiratory and respiratory involvement and myotonic dystrophy is really trying to consider the questions that you often have in mind and try to start by those and trying to be as clear as possible, because actually it is a tough problem and there's sometimes often confusion as to what is the symptoms and what should be done. So the first thing that I thought would be useful is to make a basic distinction. So when we talk about pulmonary problems, we usually mean the lungs. When we talk about respiratory problems, we basically refer to muscles too. And because we have a muscular dystrophy, it's rather best to talk about respiratory problems rather than lung problems. So respiratory problems means respiratory muscles, and we have to think that there are basically two main groups of muscles. The muscles which are called inspiratory muscles, which make air go into the lungs and make our lungs bigger. And so these are mainly the diaphragm, the external intercostal muscles, which means the muscles here on your trunk, and the neck muscles. And here you go. And there's also the expiratory muscles, which are largely passive. It's the abdominal muscles, and again, the other muscles in the thorax. And all of these come into play to make the air come in and get out of our lungs. So why are the lungs affected? So it's not really the lungs which are affected. There is some data from the animal models which show that for one part, the toxic RNA, which is at the basis of the myotonic dystrophy pathology, in a minor component does affect the lungs, but it's really the respiratory muscles which are affected. So that's really what we have to think. It's not like a common lung problem that the pulmonologists are used to deal with. So that's why it's also common to find pulmonologists who are really or who have less experience with the problems of myotonic dystrophy patients. It's because pulmonologists are mainly used to dealing with lungs and not really with respiratory muscles. So we have to be very, we have to understand that it's because they're not used to seeing them, but we have to bring them to know what the problems are. So the lungs' main function is to get oxygen into the body and the bloodstream, and this oxygen goes to the heart, which is then the organ that pumps it to all the organs. So it's rather intuitive that the more oxygen you have, or rather the right proportion of oxygen, the better for all the organs. And the lungs also are useful to get rid of the carbon dioxide, which is really the bad gas. And so when we exhale, we blow out carbon dioxide. To do this, our lungs have to be working properly to inspire and to expire. And so how many people? So what's the percentage of people with myotonic dystrophy having respiratory issues? So again, it's not lungs, but it's respiratory muscles. And it really varies between the reports that are worldwide published and experienced in the different sites. mainly because why do these percentages vary? Well, not all sites and all states allow a complete examination of the respiratory in muscle involvement, so it may be underdiagnosed. So what I thought would be useful is to bring the experience at our site. We are a specialized neuromuscular site with pulmonologists dealing with neuromuscular patients only, both kids and adults. And so all our patients are routinely subjected to respiratory tests for respiratory muscle function. And it is our experience in over 200 patients that at least half of them have some kind of respiratory issue. Now, this does not have to alarm you, because this may just be an initial, sign of weakness, which does not really give any symptom, which is not something severe that has to be feared, but it's something that needs to be assessed at baseline. And the other point that is quite clear and is, there's rather consensus amongst the different reports, is that the older the patients, the longer the disease duration, the higher the probability of having some respiratory muscle involvement, which may need care. So there are solutions and there are options, and this 50% does not have to make you feel bad that you will definitely have something with your respiratory muscles, but it does have to alert that it's something that has to be considered. And why is this? Why do we have that many types of problems? It's because, I mean, this looks like a complicated flow, but if you concentrate on MW, means muscle weakness, if you think there's a different levels where this weakness may impact the exchange of gases, if you think of the inspiratory muscles being weak, you can't get your oxygen in, so you do have reduced volumes. You may have some areas in the lungs with the alveoli, which are the small sockets there with getting your oxygen in, which collapse or do not really inflate properly. And you may have weakness of the upper airways, which means that your speech gets some kind of alteration. You may get some swallowing problems, and this may cause, the saliva or the secretions going the wrong way and getting into your lungs. And you may have weakness of the expiratory muscles, which may impair especially your secretion management and cause cough impairment and aspiration, which means that some of your food or saliva goes in the lungs and you may more easily get infection. Now, this does not necessarily have to occur all the time and all together, but there has to be awareness that muscle weakness may act at these different levels. So the consequences may be, as we've said, that your lungs get less volume for air to come in and oxygen to come in, and there may be a high risk of respiratory infections, and the ability of getting rid of your secretions and of swallowing gets reduced, and this may increase the risk of aspiration with lung infection. So these are the main serious events associated with muscle weakness, respiratory muscle weakness. So, but what are the symptoms? Because if we want to do something, we need to know how to prevent it. And so one of the problems, but that can be, taken care of, is that compared to problems that affect the lungs, I mean, if you think of a respiratory problem, you think that you get short of breath, that you can't breathe. And that's an easy symptom to identify and to, go to a doctor and say, look, I'm not breathing properly, air doesn't come in. But this is usually what happens when it's a lung problem. When it's a respiratory muscle problem, the symptoms are not that common and they get mixed up. So they often overlap with excessive daytime sleepiness, so you may feel very sleepy. And it may be a respiratory problem rather, because the oxygen doesn't get in properly and the carbon dioxide doesn't get out properly, and your CO2, your carbon dioxide levels get high, and you may get a bit excessively sleepy, or you may feel fatigued, and it's not a muscle fatigue, it's more a central fatigue, a difficulty doing things. So we've tried to figure out a way, for instance, to identify these symptoms, these respiratory symptoms, easier in a way that we can maybe detect them early and try to do something about them. And so we figured out this RespiCheck questionnaire, which is very easy. You can find it if you want to try it and think it's useful. You can find it in this publication here. And it's just a very easy checklist of respiratory symptoms that may be useful to become a bit more aware of this potential involvement. Because sleepiness and fatigue is something which is mostly of central origin. What does this mean? This means that um, there's also our brain, which has a very important role even in controlling your respiratory drive, your respiratory control of breathing. And so there may be symptoms due to excessive daytime sleepiness, which are mostly related to an impairment of the central control of sleep and of respiration. And fatigue also can be something which is due to a central control of our muscles in general and of sleepiness in general. So there are treatments that can be considered here, and there are things that can be that we should be aware of. So why is this important? Well, respiratory complications are a frequent cause of death in myotonic dystrophy, and they can really contribute to sleep problems, which are relevant, and they represent a burden for patients with myotonic dystrophy. And one other aspect is that anesthesia can be a problem in myotonic dystrophy. So why am I saying this when we're talking about respiratory? Well, because when you have to go through surgery, and I'm talking of general surgery, general anesthesia, sorry, for any kind of surgery, for any kind of intervention, you need your muscles to be able to react properly once you are extubated, once you are allowed to use your own muscles and lungs to get back to normal oxygen and carbon dioxide levels. And sometimes if your muscles are not prepared for this, there may be complications when you are sort of trying to to recover from surgery, from the anesthesia part. So in the around the surgical period. So we really need to consider this as something that should be really taken care of. And this is why, with the support of the Myotonic Dystrophy Foundation, a group of experts worldwide have decided to sort of construct and build and make readily available a group of care recommendations based on a consensus between experts. So it's not really guidelines, it's not a diktat, it has to be that way, but it's a consensus among experts with treating patients with myotonic dystrophy with a good experience with respiratory problems and pulmonologists. And so there's also a possibility for the pulmonologists and the physicians who are working with you to refer to these guidelines and to these recommendations, not guidelines, sorry, to help in the care. And these are just to show you that since the early times back in the 90s, at least half of, depending on the series, but at least half of the deaths in myotonic dystrophy are due to respiratory problems. So it is something that we need to consider, and this applies to the adult phenotypes, and also in a minority of cases there may be problems even in the more younger patients, but this is mainly a problem of the more adult ones. And this also applies to myotonic dystrophy type 2, even though in a percentage which is so far considered to be a bit less than in myotonic dystrophy type 1, which is 1 of 4 deaths in our experience was due to respiratory problems. So the complications we've talked about, and I think that if we consider that we are maybe having too many infections over time, it may be due to problems related to areas of the lungs which collapse and which create the right conditions for the bacteria to grow, because also of the secretion sticking there. So we don't always want to think of the usual and common symptoms of respiratory complications like shortness of breath. There may be complications related more to infections and to respiratory failure because of the CO2 levels rising because of our inability of the muscles to get rid of it. So again, there are things that can be done, but there has to be the awareness that there is no such medication that can, you take the pill and your lung capacity improves and your breathing gets back to normal. It doesn't work that way. So, but there are things that can be done. So even though there's no lung specific medication which can bring your lungs back to a good expansion, but there are things that need to be considered. And it's not like when you go to your specialist that, oh no, it's myotonic dystrophy, so we won't treat that. So if there are asthma problems, they have to be treated, because those would worsen your respiratory problems. If there is a lung infection, that has to be treated. The answer cannot be, oh, it's related to your myotonic dystrophy. There have to be specific problems that have to be treated just like any other person without myotonic dystrophy. If there are problems related to the central control of breathing, for instance, excessive daytime sleepiness, there are drugs that can be used, and they do actually improve and make your quality of life better. But these problems need to be looked at, and there needs to be somebody who knows what the problems are, and they can then advise and take care of them. And if in the end there actually is a confirmation that it's the respiratory muscles which are affected, then there are things that can be done which may be difficult to accept, but can actually improve the condition. So one other thing that I know that most of the patients know it, but I think that this can be very dangerous. Oxygen, meaning, again, it's very intuitive that I can't breathe, give me oxygen. No, it doesn't work that way, because oxygen, if given alone without a ventilatory support, can prevent your brain and your structures that control your mechanisms of defense to overcome your respiratory difficulties. They can be sort of shut down by giving oxygen alone. This does not mean that if you have a ventilator already and you are having acute problems with your respiration, that you cannot use oxygen. Oxygen can be used if it is in combination with a ventilator, and it has to be used with a medical advice. If you have an acute problem with respiration and there is the intuitive action of just giving oxygen, this has to be made very clear that this should not occur without knowing that there is a myotonic dystrophy problem behind, which is really at the basis of the respiratory problem. So this is something that you really have to bear in mind. So let's talk about what to do with once we have these problems. What can be done? So let's talk first of secretion management. What does this mean? This means that if your upper airway muscles here controlling your neck muscles, your swallowing problems, your upper airway system if they are weak, you will have some difficulty coughing. Your voice may not be as strong, and your saliva will stick there in your mouth and sometimes go the wrong way. And this will cause an increased risk of infection. So, but there is something we can do about this. And what is this? So there's different types of solutions according to the type of patient. There is no rule here. It depends really on what the problem is, where the secretions stick, and how difficult it is to get rid of them. But there are these sort of vests that can be worn, which cause like some vibrations, which are really high frequency chest wall oscillations that sort of make your secretions, which are there a bit lazy, sticking on your lungs. They start moving, and then it's easier to get rid of these secretions with a cough machine, so with a cough assistance machine. So there are ways to allow facilitation of these secretions sticking there. Also, there are the cough assistance machines, which you know probably by having seen them over time and by seeing friends or patients who are close to you. And it's not easy. I mean, it's easy for a physician to say, well, use your cough machine and that's it. So I understand that it's really hard. I've seen many patients having trouble, but once you get, there are times with which you can become familiar with, and there are times which can be even used on your own without really having somebody to help you with. And they can really be of help, and getting rid of secretions really will allow your lungs to feel better. You will be at reduced risk of infections, and you will feel sort of released by not having your secretions sticking there. But it really needs time and patience, and you have to be aware that it is something difficult, but you may get there. There are possibilities that you can actually get used to it. And when should you use it? Now, again, there are no rules, but there are consensus here. It's not to be used only when you have like a cough or a flu or when something happens. There are expert consensus ideas, and that this is like an exercise. Like when you go to the gym and you get your exercise for your skeletal muscles, this allows for your muscles to exercise, because if you go through these sessions per day, 2-4 sessions per day, and one session means 3 to 5 treatments, and one treatment is 3 to 5 cycles, and one cycle is one insufflation and one exsufflation, you do get your muscles being trained by inspiring and expiring. And your lungs, the areas of the lungs which usually do not receive air, it's like when you exercise on a bike, you start going like for a few minutes, and the more you exercise, the more you can have resistance and keep going. And the same applies with your cough assist. But again, there have to be rules. You do not have to be excessive with the use of the cough assist machine. It's like an exercise. You don't want to overdo it. And you want to use it before meals, because otherwise, if you have too much air coming in and getting out, you may feel your stomach not well enough, and you may get some, it may not be comfortable. So it's usually good to have it in the morning once you get up and before you go to bed, away from meals. And of course, then if you do have a cough and you do have a flu and you have more secretions, then of course you can increase that use of the cough assist machines. But you should really try to use it the proper time and the proper way without exceeding, and that should always be the rule. And this is just to show you, you probably are aware of this video.
Neck is well supported. In, cough, out, out. In, cough, out, out.
So it's just to give you a sense of, it really takes time. It takes training for the caregiver to do it properly. It takes patience on your side to do it properly. It's like mimicking a cough act, but without tiring your muscles and acting from the inside by bringing in air and letting it out with some pressure. And there are, again, there in the recommendations guide, there are the criteria which are mandatory for starting a cough machine assistance, because it may be worse if you leave your secretion stick in there. You may get some trouble because you may actually get problems with inhaling and expiring. So, and there are here some values which you do not have to know, but your physician should know, and it's a good it's a good aid that they can refer to. So again, I think it's something useful that with the help of the Myotonic Dystrophy Foundation, as a group of experts, we've tried to set down some indications that can be useful. Again, then it applies according to the patient and the condition, but there are good hints here as to deal with the things. And again, the other thing that can be done, which is again something easy for physicians to prescribe, but it's hard for patients to accept, is the non-invasive ventilation devices. So these are basically machines that are usually needed at night. It's what are usually called the BiPAPs. And so what they do is they try to have your lungs inspire and expire without acting on the muscles, but by acting on the lungs, which are healthy, by delivering air in and delivering air out with pressures that are to be set according to the patients, and really the characteristics are very different from patient to patient. And it's usually done at night. Of course, it's not nice to have it, but it may be very useful. It's why is it not nice? Well, it's not nice because these machines may be noisy. So if you have your partner with you, it may be something which is, you have to get used to. It may be frightening for your kids to see that you're using it. But if you make them participate, you explain that it's because you are having some exercise. It's like exercising at night, and they will be aware. And if you show it to them and get them familiar with what you're doing, I'm sure that's my experience. It's really much better. You should not fear of describing what's going on. You're helping yourself, and so your family needs to be supportive and be as close as possible. The other thing which is a problem is that the masks, there are different types, and these may become a problem. But again, if you think that what you're doing really has the benefit of expanding your lungs and preventing areas of your lungs collapsing, it's really important, and it does allow your thorax to keep moving, and so it's exercising, and it doesn't get that stiff that it may become. And if you do start having some shortness of breath, especially when you move around or when you do things, this actually may reduce, because if your lungs increase, your volumes, the amount of oxygen which you will be able to allow to come in, that will make you feel a bit better, and it may improve your sleep quality, because the gases sort of tend to balance and make you feel better. And in the end, the quality of life may improve, even though you have to overcome that initial idea of just flying away and just forgetting about these machines. You don't want them, because I mean, who wants a machine to help themselves breathe? Well, nobody. But if it does really help you, you should really try to change the fear of saying, yes, let's try it and let's try to use it, and be very patient. It takes time, but you may get there. And in the end, even if you get more oxygen to all your organs, you may also get more oxygen to your brain, and your cognition, your attention, your sleepiness may improve. And so in the end, people with other muscle diseases who are using their ventilation regularly, their non-invasive ventilators regularly, prolong their life. And so in this era where the treatments are coming close for us, and there's the pharma who are working so much, and we're working with them to get some drugs for the disease in general, the better we get there, the greater our chances of responding better. So we really need to have you all make an effort to try to consider non-invasive ventilation when it's prescribed to you. One of the problems may be the masks. You know, my patients with myotonic dystrophy patients have muscle atrophy, muscle weakness. So the masks may not fit your face properly, and they may bother you. But there are very many types, and I'm sure that your pulmonologist, your physician, will find the best mask to fit your face. And you see, there's really many types. There can even be customized masks, sometimes that can be made to fit your face and your physiognomy. So don't worry if the first one that you try won't work. There are chances. And I think one other thing that I've heard from the questions that was a concern for some of the patients, by constantly using the mask, meaning constantly, I mean every night, the areas where the mask comes into contact with your face may actually cause your skin to be irritated, and your skin may even break down. But there are ways that can deal with this problem. There's what's called mask rotation. So you have to consider changing the type of mask so that the areas where your skin gets in contact with the device changes every time. There are things that can be placed between the mask and your face to reduce your irritation. And so, I mean, they may look like simple things and silly things, but they really make a difference. So please consider that there are things that you can talk about with your physician and your pulmonologist, and they can really make a difference. And one other thing is the nasal congestion or drainage, which is usually associated with the humidification, the humidifiers that are sometimes used with the non-invasive ventilation to make sure that the air that comes to you is the right temperature and humidity content. But sometimes, you know, if you do not get the right parameters, it may be too much, and you may get the idea of water droplets getting in your face, and that may make you feel like you're not breathing. So again, don't just discard the machine. Just think that there may be parameters that can be changed. The humidifiers may be changed, and they can be fit for your best conditions. So it just needs tailoring. There's no specific and definitive use of, you know, one size fits all. Doesn't work. So you really have to be confident that there can be things that can be helped. Of course, if you have claustrophobia, sometimes it helps. I mean, it occurs. I mean, it makes you just feel that you can't have something on your face. Well, really, there's nothing much there that can be done except for using the, I wouldn't really know what the word would be in English, but the things that you put in your nose without having something on your face exactly. I mean, that's not the same thing. It doesn't have the same efficacy. But there are things that can be considered even for patients who are really having a hard time with wearing a mask on their face. So again, it takes some work, it takes some patience, but there are solutions. And so who are the patients who really require non-invasive ventilation? Well, again, there are some current guidelines and recommendations. This is a bit different according to the centers and according to the states. And even the prescription varies across the borders and across the states. For instance, reimbursement in the US, I know, varies. I mean, I wouldn't really get into this because it's very different and it depends on the insurance and the state you are. In Italy, for instance, it can be prescribed by pulmonologists. I know that in the UK, for instance, the cough assistance devices, at least until a few years ago, it couldn't be prescribed by a pulmonologist, but it needed a specialist not a pulmonologist, but an anesthesia person to help for the prescription. So it may be different according to the states, but there are specific numbers that can be referred to and which can help to guide the physicians to prescribe and your insurance companies to get back to you with support. Of course, the earlier you start, the better. In general, this applies to treatment options. For ventilation and for the use of non-invasive ventilation, there are now reports coming out, and it's also our experience that, in fact, the patients who have started early and who are more compliant, and compliance means being able to use the non-invasive, the ventilator for more than 4 hours per night and for more than 5 days a week. That's the minimum required to be considered, that you're actually using it properly. These patients actually have a slower decline in their in their respiratory muscle weakness. So it's actually doing something. You may not be aware of it immediately because you do not really have the lung symptoms, but your respiratory muscles are actually happy that you're using it. And that is shown by the fact that the decline in respiratory function is lower in the patients who are actually being able to use non-invasive ventilation. It doesn't mean that if you do not have the requisites, the indication for non-invasive ventilation, that you should use it like a prevention thing. No, it doesn't work. You just have to use it when there are the numbers that are required for its prescription. So again, another thing, there's sometimes a bit of confusion when we're talking CPAP and BiPAP. Again, I don't want to give the sense that one is better than the other, but they are different things. So CPAP is basically a system of tubes and masks which provide continuous positive airway pressure, which is where the letters come from. Whereas a BiPAP is a positive airway pressure, which is a ventilatory technique. So they're actually quite different things, but there may be patients who may benefit from a CPAP, whereas most patients usually benefit from a BiPAP. But it doesn't mean that if you have a CPAP, you want to shift to a BiPAP. It has to be prescribed and again tailored according to the patient and its condition. And now just to, if we maybe had forgotten for like, what, half an hour, we're in this COVID mess. And so one of the questions that have come to very commonly among patients, but also among us physicians dealing with myotonic dystrophy patients, has COVID-19 impacted more than it has impacted other patients or other people? So there's not much out there yet. I suggested these articles here because I think that they may give some hints as to what's going on, and it's a bit contradictory. So we have this article here describing a few patients with myotonic dystrophy patients who have had it's 3 patients with very many comorbidities who have had a major impact from the COVID infection. Our experience at our site and in Italy, as you know, we have also been one of the countries initially with a high impact of the COVID-19 pandemic. We have not found an increased mortality amongst our patients with myotonic dystrophy. but this is not a rule. It depends on, again, on what is the patient's condition to start with and how early the detection of the infection has occurred and how that was treated. But there is really no rule. We have had young patients who have had no symptoms, older patients who have had symptoms like a flu type infection and no major consequences. We have unfortunately lost patients with myotonic dystrophy. We do not have, personally, at our site, the numbers of patients with myotonic dystrophy are not different from the others without any other muscular dystrophy. The severity and the impact depends on the comorbidity, and the actually very different from amongst the different people. So I thought I would give you our experience, but in any case, patients with myotonic dystrophy, at least in Italy, they belong to a priority list with of patients who are more vulnerable and who should be treated with biggest attention in case of infection and with a priority list for the vaccines. Again, if the question would be which vaccine, there's no rule. As you have heard, and I think it's happening worldwide, there is no best vaccine. I think I can say that without being sort of biased by anything. I think that according to your condition, your age, your situation, and what's available in your country, I think that that is what we have to stick with, and that's working, and there is really no need to get into sort of a fight amongst the vaccines and what's best. But and the way that's being dealt with varies amongst the states. And I said, and as I say, we have a priority list for the patients with muscular dystrophies in general, and myotonic dystrophy is amongst those at the top of the priority list to be vaccinated. Again, other things that can be done, and that may be a question for some of the patients, is are there some exercises that I can do in my everyday life that can help me with some breathing problems? So anything that is can sort of be an exercise for your respiratory muscles, like yoga, tai chi, singing, and things like that, can really be exercises and help you. Every time you do these things, whether in a gym for skeletal muscle or whether doing things for your respiratory muscles, you never have to exceed your fatigue limits. It always has to stay within your capabilities. You should never try to go beyond that, because that's never useful. And you should also try to be constant, because if you do exercising and you are like acting as a hero and doing a month of extra activities and then you stop and then you start again, that's not useful. It's worse. You should try and be constant, but regularly doing them. That's going to help you. And so I think this use of a nebulizer with the cough assist, I think we've addressed already, but I just wanted to convey again that there is no rule. It varies between the countries and it varies between the patients, but they can be tailored. Humidity and the droplets that are associated with the nebulizers can be tailored. There are some exercises which are usually not recommended because they are basically acting on your respiratory muscles and making them feel more tired. So exercises which are usually traditionally used for respiratory exercises, they make you blow in tubes and, lift, reach the maximum or move these balls up, and you're happy if your balls get up and you actually feel that you're doing great. But these exercises are mostly used for patients, for people who have lung problems. We're talking respiratory muscle problems. So there may be a need for them. I'm not saying that these should not be done ever, but you want to make sure that your pulmonologist knows that we are talking respiratory muscles. We're not talking lung problems. So there may be cases when these are useful, but in general, if there is no lung problem, but a respiratory muscle problem, these exercises may cause fatigue. Now, again, we've mentioned that the myotonic dystrophy type 2 patients also have lung problems, and that in our experience, 1 in 4 patients may die of respiratory problems. We know that myotonic dystrophy type 2 is very similar to myotonic dystrophy type 1, even though there are very specific differences. So the question is again that it's the recommendations really apply for myotonic dystrophy type 2 patients just as for type 1. And you may want to consider the same type of symptoms and the same type of approach. The only difference is that the frequency and the risks of being affected by a respiratory problem are maybe a bit less frequent than they are usually for DM1 patients. But this is not so, I mean, there are not that many reports on this, so we just want to consider that they're similar yet with differences. So at baseline, the pulmonary assessments, all patients should receive with a diagnosis of a myotonic dystrophy should receive a baseline pulmonary assessment. And according to, and here again, there's recommendations, according to what the baseline condition is, then there's further testing that can be done. They should not be done if there's no need. But according to the type of involvement, there are things that should be done at baseline to have a starting point. And then follow-up assessments are recommended, even though there are no symptoms. And this means that it doesn't mean that you have to go through a whole battery of respiratory tests, but there are things that are usually recommended. And it, again, depending on where you start from, it can be every 6 months or every year. According to the condition, it may be even be more frequent if there's a case, but again, you have to refer to your pulmonologist. And so the symptoms that are to be looked for, that you should become sort of a bit more aware and alert, again, are less commonly associated with lungs, but if you do feel shortness of breath, especially when you lie supine or when you do some kind of fatigue and exercise, it's not a muscle fatigue, but it's a shortness of breath, really you can't bring your air in, then that should sort of make you a bit alert. If you have some difficulty sleeping, because as we said, it may be, these symptoms may overlap with excessive daytime sleepiness or with fatigue. You may get unusual morning headaches, for instance. You may have difficulty concentrating in the morning, and then you may start getting symptoms of having the feeling that you really can't take a deep breath, or your cough gets weak, your voice gets weaker, and you can start having, frequent respiratory infections. So these are the symptoms that you may start to look at as, a bit suspicious there. And once you get to your pulmonologist, you will have pulmonary function testing, which vary according to the need, of course. And again, you will be prescribed with ventilator support only if needed, and there are an oxygen just if you have the need in combination with your ventilators. So again, there are no rules here. It really depends on the pulmonary assessments that you're getting. When we talk of spirometry, just to show you, you will be asked to blow into a tube, and then you can get all the volumes of air that can be kept in your lungs and be inhaled and exhaled. And it's intuitive that it really depends on your cooperation, because if you understand that you have to have your lips seal this tube, otherwise the air gets out, and we will get a false idea that your lungs do not are unable to get a proper lung volume, but instead it's because you're leaking air from your mouth. So that is something that you really want to work on and do it properly. There are ways to overcome this. There are other tests that can be done, but these depend really on your condition. So there is no rule here. Oximetry means that you will be tested at night for your oxygen exchange. Arterial blood gas means that you will be taking, like at that time, you will be your blood will be tested for the content of oxygen, carbon dioxide, and other things at that precise moment. There are ways that you can test your inspiratory and expiratory muscles by looking at the pressures they are able to generate. If needed, you will be asked to have some x-rays to see the lung volumes to exclude that there may be some secretion sticking there, some infections there. And you may also be asked to go through a sleep study in case there's excessive daytime sleepiness, because sleep problems are really something which is overlapping with respiratory problems, and there can be, you may often hear about apneas, sleep apneas, and there can be due to obstructive events, meaning that when you lie down, you cannot breathe because your airway system gets sort of blocked. Or there can be problems like you won't breathe. You aren't able to breathe because your central control of breathing is affected. And in myotonic dystrophy, there's a mixture of these things, usually a predominance of the central type of problem. So there are ways to test it, and you can get a sleep test to look for the apneas, and this allows to test all these things and get a good idea as to where the problem is, and then give some insights as to deal with it. So to conclude, I'd like to give you some take-home messages, which I hope will stay with you. So breathing involvement in myotonic dystrophy is actually variable, but it's there and it needs to be assessed at baseline. And it affects the muscles, the inspiratory and expiratory muscles, and it's really not talking about lungs. And it does cause morbidity and mortality, illness and death. So it's really a problem which needs to be something to be aware of. Oxygen alone can cause problems, and we want to be very cautious there, as we've said. We need to have routine pulmonary assessments, at least at baseline, and then according to what the condition is. We do not want to wait for symptoms of respiratory involvement, because those may be very variable in myotonic dystrophy, and there may be treatments. So there may be things that can help you. They're very tough things to be accepted, but they can help you. So you want to be proactive with this. And sleep assessments are also important and part of the consideration of respiratory problems. One thing that is always useful is prevention. So if you take you try to avoid influenza and respiratory infections, and get your vaccines for flu and for whatever is there according to the time period, it's obviously useful. Enforce hand hygiene. I know this may sound very silly, but that's very important, because it avoids making you more likely to have an infection. And if you are sort of like in the winter time, you may want to avoid staying close to people who are sick. Now with this pandemic, we're getting more used to and more aware of how infections can actually be very easily transmitted. So we are maybe now better at this, but we really want to consider that we may be a bit more liable to and more fragile. So we want to protect ourselves, and we need to remember this. And one thing again that I want to stress is that any myotonic dystrophy patient can go through surgery in general. So it's not that, oh no, you have myotonic dystrophy, you can't do that. Yes, you can, but you need to do it properly. And one thing that has to be done to face general anesthesia is that you need to work on your respiratory condition prior to surgery, because you may have a delayed recovery after surgery. You may have problems with secretions just because of the surgery period. You may have been a person with the ability, a good capability of getting rid of your secretions prior to surgery, but with surgery, because of the tube, because of the drugs, because of your lying down, your secretions may increase. And if you are not prepared to dealing with them, you may have problems after the surgery. The surgery may have gone well, but you may get worse because of the secretion. So you really want to have a good assessment before you go through surgery. And also you want to remember that there may be some medications that may worsen your condition, but this is something which is well known. And again, in the care recommendations, there are a list of drugs that should be used with caution and or should be actually avoided for myotonic dystrophy patients. And one last thing is the emergency awareness. You want to have an emergency card stating about your disease and what's best and what should be considered, and bring your ventilators with you and your cough assistance machines if you have them with you when you move around, especially if there's an acute problem and you need it. And so you really need to be an advocate of yourself and be proactive and refer and work in alliance with your physicians and your associations, patient associations. And I'm happy to take questions if you have any other ones. Thank you so much.
Thank you, Dr. Sansone. This was fantastic. There's so much incredible information here, and I think it's going to be very valuable for the community. We do have quite a few questions, and I'm recognizing it's also, it's also after 1 o'clock here. But if you're comfortable and you can take a few of these questions, we would be grateful. There are some very specific. Great.
I'm here to, so if it can help, I'm happy to.
Okay. All right. So we'll jump in. One, and this is just to reconfirm, I think, some of what you've already presented, but is diminished lung capacity a symptom of DM1 or DM2?
So diminished lung capacity, yes, it can be sort of a hint that your respiratory muscles are not being able to expand that much, and so your volumes are getting a bit smaller. So if you are seeing that your lung capacity is gradually decreasing, you may want to consider talking with your pulmonologist about this. And there's no difference whether you're a DM1 patient or a patient with DM2. But it does suggest that your volumes, the ability of your lungs is getting a bit reduced as time passes, and your oxygen is getting in less as time progresses. So yes, something is getting worse.
Okay, thank you. If you've aspirated something, how can you prevent it from turning into pneumonia?
Okay, so there is really no rule there. If you've aspirated something, it means that your ability to deal with secretions and your glottic function is not 100%. So not every time you have aspiration, you get a lung infection, but definitely depends. Of course, it depends on the amount of aspiration and what's aspirated. If you are familiar with a cough assistance machine and you use it regularly, there may be ways of, if it's still in the upper airway systems, the cough assistance machine may help you get rid of what's there before it gets aspirated, but you have to be familiar with the settings to use it properly. Once it's in, there is really no way that you can prevent pneumonia if that's the condition that's starting. But if you have an episode and you recognize that something has gone the wrong way, then you want to make sure that you go to your physician and talk to him or her about it, because you may want to have an x-ray and see if that's exactly what's happening, and you may want to treat early instead of waiting for symptoms to get worse.
Thank you. This question is very specific to a particular family. So our daughter is having spinal fusion surgery in June. She just did a pulmonary assessment prior to this long surgery, and she failed the lung function, and her lung capacity is 30%. Her oxygen level, though, was 95%. We're trying to strengthen her muscles with a cough assist and other tools such as the BiPAP. Do you have any other recommendations? And what are your thoughts on the 30% lung capacity? We were told that it will get lower during surgery.
Yes, so I think that it's a very good thing that that this family has actually done everything that was to be done, because the respiratory assessments and the support for ventilation and for secretion management was started prior to surgery, and they're trying to stabilize the function as best. And so I think that is something important that they're doing, and they will probably have some improvement there of the lung capacity and of the secretion management. However, 30% is actually a low number, and surgery does cause a worsening no matter how you exercise before. It does cause, in general, it causes worsening of the lung capacity. So that has to be considered in dealing with the surgery. And I think that it really comes to what is really needed and what are the pros and cons. If surgery is required, I suppose that's already the decision. So, but the lung capacity with these numbers is something that has to be considered as potentially, yes, worsening during the surgery. But if surgery is needed, exercise and getting ready for the surgery and getting ready after the surgery with of course the possibility of intensive care to overcome the potential problems there. That's the best I think that can be done. So if I were the family, I would think that I'm doing the best thing that I'm doing. The only thing that I have no elements, and I don't think I should even comment on this, is really consider the pros and cons of facing surgery. But if surgery is necessary, then the family is doing the best thing they can.
Thank you. What is the best way of breathing? To inhale and exhale through the nose or the mouth? In through the nose, out through the mouth? What do you recommend?
Well, breathing is usually something we should not think about. It's something that should come spontaneously. It's a reflex thing. So I think that you just do it the way it makes air gets in as best. If you need to open your mouth to inhale more, it's because you are really getting tired, because and the flow and exchange of gases is not really smooth, which means that there is exactly some fatigue in your muscles. So it's not that by opening your mouth it is the right thing. I mean, you don't want to walk around with your mouth open to breathe better. It's an indication that you are tiring. So if you think that you need to to take some deep breaths very often, it's because your muscles are getting tired. So you want to have an assessment of your pulmonary function and see if there's something that can help you recruit more parts of your lungs, maybe with some exercises. There are some air stacking exercises that can be done to increase the areas of the lungs that can come into play with the gas exchange.
Okay, thank you. This one is specific to a sleep study. I did a sleep study and got the report saying I had 19 events per hour. I was told that that was moderate. Is that so? Right now, I use a BiPAP and have events between 3 to 12 an hour, depending on the night.
Okay, so yes, I think what the conclusions are correct. I agree. These events mean that there are not, this is a recording period, and there are some slots of time, just to say it very grossly, but so that we maybe get it easily understood. There are some events, are some time frames along this recording, and they should not be that high. I mean, these are events where you do get sleep apneas, like the ones that I was talking about. So there are people who get more than 30, so that's high. 19 is something that sort of like, yes, moderate. But it does still mean that you do have these apneas. So using a ventilator can actually improve these numbers and make your gas exchange much better and your sleep quality much better. And this should impact your daily lung function and your daily activities. So I think you are doing the right thing, and you've been given the right answers.
Great, thank you. We have one question just asking if you could comment on the Trilogy machine, if you're familiar with it, and what your thoughts are for the DM community.
Okay, so that's a very specific question. That's a very pulmonology type of question. It's a type of ventilator. And again, there is no best ventilator that can be used. According to the type of patient, there are different triggers that can be set for the machines, different ways air can come in and sort of be and be triggered by the patient, or automatically set by the parameters by the machine. And there are different settings that can occur, and so I wouldn't be able to give you specific answers as a pulmonologist would, but I know, and I've been using it with my pulmonologist at my site. It's a very good machine, but it doesn't mean it's the best machine, and it really depends on the type of situation that each patient has. Some patients find themselves very, I mean, their respiratory insufficiency is really very well taken care of with the Trilogy, others with other types of ventilators. So it really is something that should be tailored according to the patient.
Okay, that makes sense. We have another question about familiarity with esophagus spasms. Is that a common symptom of this disease? And is there something that one might be able to do to reduce the frequency of the spasms?
So esophagus spasms, meaning when there is a ventilator, the feeling of constriction when you try the ventilator, or a cough machine, or without these devices?
I'm sorry, they didn't indicate in the question, so I'm not
Okay,
sure.
so there are some patients in whom when you try the mask and the ventilators, instead of feeling air going in, they get spasms in their glottic function and their upper airway systems, and that makes them feel even worse. But that's only when you use these type of devices. So if that's the case, I mean, that's a feature, it's like an intrinsic characteristic, and there's really hardly anything that can be done to overcome this that I am aware of. If it's spasms that occur without any of these devices, it may be something to do with myotonia, even though in my experience, this is not a common symptom. Actually, more common is the fact that some patients feel that they need to use water as a sort of a push thing, as a drive force to bring their food down, which is not something which is usually recommended by logos and by physicians. But there are patients in whom the esophagus is like a tube, and what the patients do is they put their food in their mouth and then they use water as a pressure to drag the food down, which is something which makes physicians very concerned, because it really the different consistencies of the food, liquid and solid, is something which is usually not recommended to be together, because it facilitates the risks of aspiration. But when the esophagus is like a tube, there are patients who instead find it much easier to swallow by doing this, which is not something I recommend. I'm just reporting what the patients tell me and how they do it. The spasms of the esophagus is not something that has been a complaint in many of my patients, so I'm not sure that I really understand what probably if I had the patient and I could talk to them, I could maybe be of greater help. But just with this, I'm afraid I'm not really able to say more than what I said.
Okay, that's fine. That was great. We have really just sort of one last question, and it's a little bit more of a summary maybe of what you've talked a little bit about regarding respiratory weakness and COVID-19. So you did say that it's very different between countries and it varies between states within the US, and even within the US we know that vaccine priority is different even within each county within a state. So is there something that we can do to make sure that DM patients are given a vaccination priority over healthy recipients? Do you have any recommendations for that?
Well, I think that if I were in the States and I was working there, I would simply say that myotonic dystrophy patients are at risk for lung infection because they have a respiratory muscle weakness, and that they have comorbidities which are known to be what the virus, which this COVID-19 virus like. So we want to consider that even though they may not have overt symptoms of respiratory involvement, they are definitely at risk for respiratory muscle weakness, and they do definitely have comorbidities. And the combination of these two things makes them very vulnerable to COVID-19 infection. So they should deserve to be vaccinated before other healthy people without comorbidities. That's what I would say.
Okay, that is helpful. And I will follow up with that and say that we have had some people reach out to MDF and let us know that they have been successful in getting their doctors to sign letters for them that say they are at higher risk for respiratory infection and that they do have comorbidities. Those particular people have been able to take that letter to the right authorities who are providing vaccinations, and they've been able to be moved up the vaccination list. So I know that that's not going to be the case for everyone everywhere, but those letters that indicate exactly what you've just been saying have seemed to be, they've been helpful for some people.
Good.
So I don't see any other new questions that have come in. So I think you have done a fantastic job answering all of the questions that came in. I apologize for how long we've gone over. We're so grateful that you were with us tonight, which is now what, almost 9:30 for you. We are really, really grateful for your time and your expertise to share that with us so that we can continue to grow and to learn and to make sure that we stay as healthy as possible.
Yes.
I think that this is it. I want to just remind folks that this will be posted to the Digital Academy when we are done, and probably give us a couple of days at most. But also, if you have questions, you want any follow-up, don't hesitate to reach out to MDF, and we would be happy to also follow up with Dr. Sansone if necessary. Otherwise, I'm going to wish everyone a very happy Friday, and thank you again, Dr. Sansone, for being with us and for just being so gracious with your time to help us understand as much as we can about our lungs and respiratory issues with DM.
Thank you. I hope I was useful, and I am available for questions even remotely through you, and I'm grateful for your help with the patients and for giving me the opportunity of sharing my experience. Thank you all, and have a good Friday.
Thank you.